Overall, I've been traveling back and forth, but I set up the first corporate pediatric ICU at Apollo Hospital in '98. The cardiac experience mainly comes from Boston Children's and Shands Children's Hospital, now in University of Florida. BL Kapoor at this time is not a major cardiac center, but we have just begun doing it. Of course, Escorts has been doing heart surgeries, and Narayan Dayala and many. So what I'm going to talk about this morning is basically just take you through some cardiorespiratory physiology rather than giving you a particular recipe, and then you can make your own decision as to what ventilator strategies are best for you. We all know that oxygen delivery is maintained by adequate cardiac output, ventilation, oxygenation, hemoglobin. So this is nothing new that I'm telling you, but I just want to sort of put it all together so that while we are talking about all of these different pathophysiological states of plumbing problem with the heart, which is getting totally corrected or partially corrected, so that we know what the cardiorespiratory physiology and interactions are. Of course, sedation, paralysis, and now thermoregulation, more so in neonatal and smaller age group, hypothermia, I think is now state of the art. We also, as intensivists, need to learn to deal with post-operative issue related to cardiopulmonary bypass. As we know that there is a loss of pulsatile flow, capillary leak, vasoconstriction, renovascular effect. It's almost like a controlled state of shock where you have a lot of SIRS, systemic inflammatory response syndrome, cytokine release, endothelial damage. And therefore, what the bottom line is that you have a bloated patient who's got capillary leak and who's got interstitial edema in all the areas, including the lungs and the heart and cardiac muscle. So it causes fluid retention due to capillary leak, usually resolves in 12 to 36 hours depending on the duration of bypass. So coming to how all of this affects us when we have to take up a ventilation strategy in the post-operative period. As we know, oxygen delivery is cardiac output and oxygen content, and conventional ventilation strategies which we are using to manipulate pulmonary vascular resistance using the PEEP rate to affect the pH, PCO2 and PO2, and occasionally the other gases like nitric oxide are needed, but usually we get away with milrinone and sildenafil. So I'll just highlight one case and give you some multiple choices. Previously healthy 2-month-old with post-op L kappa. L kappa was just talked about. Echo showed severely depressed LV function. Intubated, milrinone and epi infusions. After 5 days, epi were discontinued. Echo showed a mild, moderately depressed LV function. And 2 hours after extubation, there is acute hypotension, tachycardia, poor peripheral perfusion. So the deterioration in this patient's clinical status after extubation is best explained by, and let me just say this to have this cardiorespiratory physiology in your minds. Increased RV load after load, increased LV after load, decreased LV preload, decreased RV contractility, or increased RV preload. What happened? So this just makes a point that if you have a failing left ventricle and you put somebody on the ventilator, the LV after load reduces. That's how ventilation helps. So in this particular case, the LV after load went up, so the patient failed. So I think it's important to keep those things in mind, other than, of course, when we do extubation readiness test and look at the lung function, the heart function, electrolytes, temperature, all those things as extubation criteria. So what is the effect of positive pressure on the left ventricle? Increases intrathoracic pressure, increases cardiac output by decreasing the left ventricular afterload. If you can just remember this, keep this in mind, it helps. If I were to tell you that this patient is not in jet, the rhythm is fine. What in this particular case could have happened? So you could get into acute pulmonary crisis, okay? And this is one thing that you have to think about, that if you were to hyperventilate and bring the CO2 down a little bit, you'll have this patient. So these are just few of the cardiorespiratory physiological things that I just want to, there's a detailed explanation, and I've just pulled this question from one of the cardiac intensive care and pediatric ICU board review. And I think these are very common situations, so we need to. So what is the effect of positive pressure on right ventricle? Increase in intrathoracic pressure decreases the cardiac output by decreasing the RV preload, and this may increase the PVR. In general, the best strategy for the failing right ventricle is to limit intrathoracic pressure. So we know that, but at the same time, the patient who is having a failing left ventricle gets tremendous benefit by putting the patient on the ventilator. So lung volumes and pressure affect the preload and afterload on the heart. Increase in the lung volume and intrathoracic pressure decreases the preload to both right and left atria. Also, one more important physiological fact that I want to bring to your attention: too much hyperinflation of the lung alveoli compresses the pulmonary capillaries, increases your pulmonary vascular resistance. Too much of atelectasis causes kinking of all these vessels, therefore increases your pulmonary vascular resistance. So what do you need? Just the right lung volume. And what is the right lung volume? FRC. At functional residual capacity, your pulmonary blood flow is the best. So not too high of inflation or not too much of atelectasis. Is there an ideal mode of ventilation? Well, cardiorespiratory interactions vary very significantly between patients, so it's not possible to provide specific ventilation strategies or protocols. But mode of ventilation has to be matched to the hemodynamic status of each patient to achieve adequate cardiac output. So this is all of you are familiar with, showing any of the cold stress or suctioning, acidosis can precipitate pulmonary hypertension. And what we need to do is to basically all of this post-operative cardiovascular care in the pediatric ICU, in the cardiac intensive care, revolves around manipulation of this pulmonary vascular resistance, making sure cardiac output is good. So if there is a low output state, how to manage that, and making sure and doubly sure that the plumbing is okay. So the repair is adequate. That needs to be controlled.